Dr. Cleveland has asked me to present infectious disease information for you all. You will either have had this information already or you'll have it in more depth in the future, but this is a review for emergency medicine. Let me start with a case. A 28-year-old male farmer presents to the emergency room. He's got swelling of his leg and a rash. He reports decreased urinary output and loose bowel movements for 2 days. He also has shortness of breath. So his vital signs, he has a temperature of 103, his pulse is 120, blood pressure is 110 over 40. So although the 110 is fine, 40 is low, he's got a heart rate of 40. So immediately, you know, even before anything else, he's got systemic inflammatory response syndrome. He's got a rash, erythematous blanching rash. He's got warm pitting edema, so he looks like he has some cellulitis. So you can also suspect that he has sepsis. He's got decreased inspiratory breath sound, so he has a symptom. He's got several foci of infection. So in this particular situation, what might he have? He could have bacteremia. He probably has sepsis. He could have septic shock. There's been no fluid challenge yet. He definitely has systemic inflammatory response syndrome. So he definitely has SIRS, although he could have any of these other three as well. So he's taken to the ICU. They do everything they're supposed to in the 6 items to do in sepsis. So they do a blood culture, they give him fluids, he should have oxygen, he should get a lactate, they check his urine output, hopefully in the ICU. He worsens over the next 2 hours, he's got worse shortness of breath, and he's got a decreased blood pressure. So he did receive dopamine, and they increased his rate. He was unresponsive. He failed to respond, went into cardiac arrest, and he was declared dead. So it shows you how quickly someone that presents with this kind of infection can go bad quickly. This particular gentleman had staphylococcal toxic shock syndrome. So toxic shock syndrome is caused by Staph aureus. It's in 30 to 50% of healthy adults and children. You can find it in the nose. Sometimes people harbor it there. Skin, vagina, rectum. In particular, toxic shock syndrome is related to toxic shock toxin number 1 or staphylococcal enterotoxin B. These other A, C, D, E, H are less common. They're super antigens, so they cause an exaggerated, dysregulated cytokine response that is different than what you would get from a regular infection. It's usually not purulent, although if you have purulence, you can still have toxic shock syndrome. It's a multisystemic infection. There are about 1 out of 100,000 cases per year. 50% are non-menstrual. Back in the 80s, there was an increased incidence of toxic shock syndrome related to tampon use. And so women were using super absorbent, and they were using non-cotton, which means it was less absorbent. And they were saying that you could leave it in for longer periods of time, and that created an environment where the staph could grow, and they created an increased incidence of toxic shock syndrome. It can occur in children with non-surgical skin lesions. It can be methicillin resistant or methicillin sensitive staph. Women have it more commonly than men. It can be found in wounds, again, tampon use. People who are immunocompromised can have it. Skin infections like chickenpox can cause problems. Impetigo, the same problem. They start having staph infections, secondary infections. Mosquito bites, the same issue if they become secondarily infected. Non-steroidals are not implicated in the cause, but it's associated with it. So people that have it have been taking nonsteroidals either because they've had severe trauma, which puts them at risk, or they have symptoms and it's masking the symptoms. This is the CDC definition of staph toxic shock syndrome. They have to have a fever of 102 or greater. They have to have a rash. They have to be hypotensive, so that includes the definition for systemic inflammatory response syndrome, or less than 5% by age if they're less than 16, or they're orthostatic by 5 millimeters of mercury. And they have desquamation 1 to 2 weeks after the onset, so they may not have that desquamation, or they won't have the desquamation at the time. They'll have it afterwards. And they have to have 3 or more of the following organ systems. So he's got diarrhea, he's got musculoskeletal pain. He probably had some renal problems because he had decreased urinary output. So he meets the criteria for staph. And he's negative for these other conditions, Rocky Mountain spotted fever, measles, and leptospirosis, which can masquerade as toxic shock syndrome. These are some of the presentations that people present with. I'll let you read these over. But they're complicated cases, so someone can have sinusitis and then they end up having toxic shock, so they become much sicker than just the presenting illness would otherwise cause. What's the differential? Strep can look identical. It can be associated with increased pain. They can have necrotizing fasciitis, although that can happen in staph as well. Scarlet fever with the strawberry tongue and the sandpaper rash with pharyngitis. Scalded skin syndrome, it's also caused by staph. They'll have bullae and they'll also have desquamation. Meningococcal, they'll have petechia, purpura, meningitis. They'll be sick also. Rocky Mountain spotted fever, measles, and leptospirosis we'll talk about in a moment. So with Rocky Mountain spotted fever, the rash begins on the extremities first. It's petechial, and it occurs 3 days after the fever begins. In Kawasaki disease, it's more common in children, and there's more extensive lymph node enlargement. With dengue fever, they should be coming from an endemic area where they have mosquito exposure. Leptospirosis is uncommon and would be in this case of a patient who's a farmer and he works with soil or animals, but it's not a common infection. Stevens-Johnson syndrome is related to medication use, and if you suspect the patient has it, you can order a glucose 6-phosphodiesterase test to see if they have a deficiency, and that would help make the diagnosis. But the extensive skin and mucous membrane involvement could also look the same as staph, toxic shock syndrome. This is what the rash looks like. It's not very impressive, and it looks kind of like a sunburn. It can be maculopapular. Here's another image. It's toxic shock syndrome. Here's the desquamation that's associated with it. And here's the desquamation of the palms, which can also occur on the soles of the feet. What labs do you order? The ones that you would usually order to work up a patient who's sick like this. CBC with the differential to see if there's a shift and an increase in band neutrophils. You order a CMP to check the liver and the kidneys and the electrolytes. Lactate level, because that's one of the 6 that you need to check for sepsis. CSF if they have a headache or meningeal signs. CPK to see if they have extensive muscle involvement. Blood cultures, which you should do, again, checking for sepsis. Culture any wounds that are there. And chest x-ray or CT, ultrasound, any other imaging that might be useful to see if there's an abscess or an infection in one of the deeper organs. How do you make the diagnosis? They fulfill the CDC criteria, or you have a high index of suspicion. You don't have to isolate the bacteria to make the diagnosis. That won't be happening in the ER anyways. You have to explore wounds and do a pelvic exam to be sure that someone doesn't have a tampon that's still there. And that sometimes happens with women. They forget that they have it in there, and then they get sick, and then you can find the source of infection, and that would increase and markedly improve the patient if you take away that source of infection. There is a test called the Veregene gram-positive blood culture test. The diagnosis of the bacteria can be made in hours. It's a DNA amplification test, and there's a 93% sensitivity. This also checks the sensitivity of the antibiotics, so you can know if the antibiotics you're using preliminarily will be working. The patient has to be admitted, call an infectious disease doctor, and treat as they would in sepsis. Now, the antibiotics of choice for staph toxic shock is clindamycin. If it's methicillin sensitive, you can use nafcillin. If it's MRSA, you would use clindamycin, vancomycin, or you can use linezolid alone, because linezolid is also a protein synthesis inhibitor. But sometimes you won't know that, so you need to start them on a broader spectrum group of antibiotics, maybe vancomycin with ampicillin, sulbactam, unicin, something of that sort. So they would have to be broader spectrum antibiotics. If it's severe sepsis, so unresponsive to fluid initially, you can give IV immunoglobulin for 1 day, and that helps people who are in septic shock and refractory shock. Here's another presentation, a 36-year-old female paramedic. She's postpartum for a week. She sees a black spot on the back of her leg. So she's an astute paramedic, and she says, oh, maybe I've got a blood clot. I should go to the emergency room. But she didn't have a blood clot. She had strep pyrogenes, and that's group A streptococcus, so that's GAS. So that's different than gas gangrene, which we'll talk about in a moment, where patients have subcutaneous emphysema. They actually have gas-producing bacteria. So group A strep is it's the culprit in toxic shock syndrome of strep. The bacteria also releases superantigens, and again, typical entries are the throat, vagina, or the skin. No portal is found in 45% of the cases. A little bit higher incidence in the United States. There's a 30 to 60% mortality. So again, toxic shock, it indicates a higher mortality. It can happen to anyone at any age, associated with skin trauma, again, areas, the mucosal membranes, surgery, again, use of nonsteroidals, corticosteroid use, or people who are immunocompromised. Even minor trauma can cause toxic shock syndrome. Viral infections can predispose people to it, and again, the postpartum state. The CDC criteria, they have abrupt pain. There's isolation of the bacteria, and again, in a large part, many of the patients, you cannot isolate it, so it's hard to make the diagnosis. Hypotension, again, toxic shock by definition. They also have to have 2 of the following. So they've got renal impairment, coagulopathy, liver impairment, ARDS, rash, and soft tissue necrosis. Now, this particular patient did go into necrotizing fasciitis. And this was someone that saw symptoms early that felt good. She just had the rash, and so she went to the hospital, and it saved her life even though she had significant sequelae. Patients with toxic shock syndrome can also have necrotizing fasciitis. This is one of the 3 causes of necrotizing fasciitis. So we talked about that in surgery. This is like the tip of the iceberg. You see a patient, they've got lesions that are this big, and they've got extensive damage underneath. So when you do surgery, you see that they have this devitalized, mushy tissue. It's not firm and healthy looking, just like if you're a meat eater and you have a nice cut of beef. it's nice and thick and firm and not mushy, and it doesn't, you stick your finger in it, it doesn't give way. That would indicate either it's been frozen before or there's bacteria in it. This is a photo of necrotizing fasciitis. So again, they have this much involvement. You can guarantee they're going to have a deep debridement with lots of tissue loss. Could even be a possible amputation. So treat as in septic shock. So you do the 6 essentials. Early surgical intervention is extremely essential. The antibiotics penicillin and clindamycin will treat that. If you're uncertain, clindamycin and a carbapenem like Primaxin, beta-lactamase like Unicin or Zosyn. You can use vancomycin. Again, linezolid is an excellent antibiotic. It's the same kind of protein synthesis inhibitor like clindamycin is. So that would work instead of clindamycin. Intravenous IG, immunoglobulin for 3 days is also very helpful. So very similar treatments to staph and strep. So I told you that necrotizing fasciitis is caused by strep. It can also be caused by Clostridium perfringens. It can also be polymicrobial. So fascial necrosis in gas or air gangrene is characteristic of necrotizing fasciitis, usually from an open wound. There was a case where someone went zip lining and they cut themselves and they fell into some water and they had a severe case of necrotizing fasciitis. The skin is just like the photo that we looked at before. There can be fever, tachycardia out of proportion to the fever, so they might have a really rapid heart rate. How do you know? The heart rate increases 10 beats per minute for every degree Fahrenheit above normal. This is a photo of a patient who would lick or grease the needle before the injection, and it helps the needle go in. This is something that intravenous drug abusers would use. So this is necrotizing fasciitis of the arm. This is a severe case from someone who had been binge drinking, so alcoholic. It's a true disease for someone to keep doing this and to have this happen to them. This was caused by Clostridium perfringens. Now that you're familiar with CT scans and MRIs, here's a necrotizing fasciitis. So they've got air in the external iliac vein, and they also have gas in the soft tissue of the buttock. There. This is a patient who has it on the plantar surface of their foot. Could have been from a wound or a nail that they stepped on. So treat the same as in sepsis, broad spectrum antibiotics. Have to think about tetanus. Surgical debridement is a must. So how do you make the diagnosis of staph toxic shock syndrome? So this is my trick question. It's not hypertension, it's hypotension. So with staph, they should have hypotension, fever, rash, and desquamation after. 2 flu-like viruses. The first one is West Nile virus. It's a Japanese encephalitis virus. It's from the Flaviviridae family. I won't ask you that on a test, but it could be a PANCE question. Can't guarantee it, but it could be. It's caused by mosquitoes, and it's found in areas where there's an incidence of West Nile virus. Produces a flu-like syndrome, headache, fever, body aches, meningitis, flaccid paralysis, and muscle weakness. There's a rash, which indicates less severe disease when it comes on. Here's the rash of West Nile virus. Again, these are not very impressive, although this would be more impressive. And again, differential includes any of these infections that have rashes. So things to think about: influenza, dengue, Rocky Mountain spotted fever, St. Louis encephalitis. To make the diagnosis, you get an IgM for West Nile virus, and it can be negative for the first 3 days. So again, it could be a tricky diagnosis to make. CBC, it can be normal, and if they have neurosymptoms, they should be checked with a spinal tap. They'll have an increased white blood cell, elevated protein, and normal glucose. The treatment is supportive. There's no treatment for West Nile virus at this time. Follow-up is important if the patient doesn't continue to improve and there's been no definitive diagnosis. So it's great to get the blood test 3 days later and follow up with a primary care physician to be sure of what the patient actually has. They can also have influenza. It can be A and B or H1N1. There are other viruses, other influenzas that try to make their way into the population, like bird virus and that kind of thing, but A, B, and H1N1 are the main ones. So again, typical flu symptoms, those of you that have had it: fever with shaking, headache, myalgia, really bad headache, respiratory symptoms. Pneumonia is the most common cause of demise in patients, eye pain, and photophobia. Reye syndrome is a complication, Guillain-Barré, acute respiratory distress syndrome. People die of pneumonia, of influenza. It's not most people get over it, but many people die from it. Lab findings are usually non-specific. If you do a culture for influenza, it'll be positive, but that takes several days to do. They are rapid strep tests for influenza antigens, which are very useful. And again, it's great to have the diagnosis because then you don't have to wonder about if the patient has something more serious. Treatment: rest fluids, Tylenol, acetaminophen, not aspirin because of the possibility of Reye syndrome. That can happen even in adults. So again, recommended not to take any kind of salicylates. When would you give antiviral therapy? If the illness requires hospitalization, if there's plenty of drugs. There was an H1N1 pandemic a few years ago. I think it was 2009. And so people were stockpiling it and there wasn't as much availability of the drugs. If they've had symptoms for less than 48 hours, there's no contraindications, no resistance in the area, or if it's a high-risk individual. Something about resistance is that during the H1N1 epidemic, patients became very resistant in a short period of time because they were giving it out for so many people. So resistance has to be watched for. The CDC does recommend antiretroviral therapy. So these are groups at high risk: children less than 2, adults greater than 65. If they've got a systemic problem, such as coronary artery disease, multiple diseases there, immunosuppression, women who are pregnant or postpartum, children receiving long-term aspirin therapy, Native Americans and Alaskan Natives, they're at a higher risk. People who are obese, residents of nursing home, they're all at higher risk. So you can treat with Relenza, preferably within 48 hours. This is an inhalation medication. It can cause bronchospasm because of the irritation. It can decrease the risk of pneumonia, also treats H1N1. Tamiflu is the oral medication. You can give it to children older than a year of age, less than a year of age if it's H1N1. Again, watch for resistance, and it treats avian flu as well. Here's a patient with sores of their mouth. This is a case of herpes simplex gingivostomatitis, usually caused by herpes type 1, although type 2 can also be if there's cross-contamination. The pathognomonic description is painful vesicles with an erythematous base which ulcerates. It's recurrent, so oftentimes they've had this before. It's brought on by stress, sun, or menstrual cycles. The stress lowers the immune system just like being exposed to the sun for a long period of time does. The differential diagnosis includes Coxsackie virus, poor hygiene or gingivitis, and aphthous ulcers. Aphthous ulcers are not as severe, they're not as multiple, and they usually are inside the gum area, where the herpes simplex is usually labial. The medication to use is any of the antiviral medication, acyclovir, famciclovir, valciclovir. 7 to 10 days for the first episode, 5 to 7 for the recurrent. Possible pain medication, opiates for children because it's very painful. Admit children if they're dehydrated. You can also use some topical anesthesia like Xylactin. Okay, this is the end of part 1.